Okay, great. So I'm really grateful for this opportunity. I know we have postponed it several times before, and now we're here. We thank God for this opportunity. I'd like you to start with an introduction of who you are and what you do. Yeah.
Okay, great. So my name is Dr. Eric Ochomo. I'm a senior research scientist at the Kenya Medical Research Institute. I'm based at the Center for Global Health Research, which is in Kisumu. And here I lead the entomology department. So that's basically the department that is involved with studies of mosquitoes, mosquitoes and other insects of importance in terms of human disease. At KEMRI, the focus of KEMRI is actually research that advises on matters of human health policy in the country. And so a lot of the work that we do contributes directly to how malaria control and other vector-borne disease control happens in the country.
Does the Global Health Research is it in collaboration with the KEMRI?
So that is one of the KEMRI centers. So KEMRI has 14 centers in the country. This is one of the centers. So I'm sure you've seen that there's a KEMRI Kisumu, KEMRI Busia, KEMRI Nairobi. There's multiple campuses within KEMRI Nairobi, KEMRI Kwale, KEMRI Kilifi, etc. So all of these are centers of KEMRI.
Okay.
Now the centers have different names.
Okay.
And the one in Kisumu is called the Center for Global Health Research.
Oh. Why did you choose to study or to venture into malaria control?
Yeah, I want to say that this life chose me. I'm actually a 3-time graduate of Mosquito University. So I did my bachelor's degree in biomedical sciences at Mosquito University. I majored at that time in what's known as medical biotechnology. And then I did a master's at the same university. But now with my master's, I majored in entomology and the science of vectors, so vector science. And then for my PhD, I did a PhD in biomedical science and technology as well. At that time, my focus was on insecticide resistance in mosquitoes. So I've always, since my undergrad, I've been very passionate about mosquitoes, because when I was actually in my first year of school, I came to KEMRI for an attachment during the end of our first year. And I got attached to the entomology lab, and I actually really ended up enjoying my experience and liking it. And so since then, I've sort of been attached to the study of mosquitoes. And so I've been here since 2005 when I first came here as an intern, and now I actually head the department. So I've sort of grown with the department over this period of time, and grown with the problems. Now I think it's an area that I'm very familiar with, and I'm able to speak authoritatively on many disciplines in this area. Yes, wow. I am. One of the main motivations for working in this area is because originally I'm actually from around here. My home is in Oyugis, which is in Homa Bay County, and so I'm very aware of the burden that malaria causes in this environment. I have personally, of course, had multiple infections of malaria, but I've also been to health facilities and seen how much we lose children and pregnant women to malaria. I see how much of an economic burden malaria is for many of the areas that I work in, and so it's something that I'm really determined to help improve. I'm also very determined to help change malaria in this particular setting, and so this role gives me an opportunity to actually make that positive impact in terms of reducing the burden of malaria in this setting.
Oh, that's interesting. They say the environment also sort of shapes even a child's career.
Yes. I come from here. I am very privy to malaria. I have experienced it myself. I've seen it in my family. I've lost relatives to malaria. So this is something that I live with every single day.
Okay, sorry. And if you don't mind, could you please tell me briefly about when malaria struck closer home?
When I was born in 1985, I was a preterm baby. Preterm meaning that I was born at 7 months instead of 9 months because my mom had a malaria infection, and it was either I had to be born at that time or I'd be lost altogether. So personally, yes, malaria was literally in my origin as a human being. And so my mother had 4 children, but currently I only have one other sibling, my younger brother. The other 2 were lost due to malaria when they were still very young. So I never actually got to experience living with them because of malaria. So this is something that I've lived with in my family.
what can you say is the status of malaria, especially in the Western Kenya?
So this is me quoting the Kenya Malaria Indicator Survey 2020, which indicates that the entire country we have a prevalence of malaria at 6%, but Western Kenya has an overall, Western Kenya here being the 8 counties of Western Kenya, so starting down from Migori to Homa Bay to Kisumu, Siaya, Busia, Kakamega, Vihiga. So those counties put together, and Bungoma, those counties put together have an overall prevalence of 19%, which is more than 3 times the national prevalence. So it means that they really are high burden. As of 2020, the highest burden county was actually Busia, which has a prevalence of about 39%, and Siaya was following closely at, I think, 36 to 37%. So there hasn't been another malaria indicator survey since 2020. Usually this happens every 5 years. So that remains the official status at the moment. Though I will tell you based on data that we have that at the moment, I think strongly that Busia might have improved slightly following the last BedNet campaign, which distributed PB on net. But we will wait until the next malaria indicator survey is done before we can give the official standing in terms of prevalence.
Okay. And why Western Kenya? Does it have anything to do with the lake?
It has a lot to do with the lake, yes, you're right. So one, the lake is fresh water. These areas are mostly lowland. So there's a lot of, I want to say, stagnant water, which provides a very conducive environment for mosquitoes to breed. Usually the biggest reason why you would see malaria in any one place is stagnation in water. So when you don't have really good drainage, and especially if you think about a plateau or a flat area basically, so water is not running off very quickly, so you end up with pools of water. And these are very conducive for the species of mosquitoes that are found in this area. That's one. Number two, there are multiple swampy areas, especially areas along the Yala River, which provide really, really conducive habitats for mosquitoes. So because of that, there is a very high population of mosquitoes in these areas. But generally, areas along the lake shore will have areas that are very flat. They have water, they have runoffs, either of rivers going into the lake or other sources of water, and those are usually very good habitats for mosquitoes. And that's the main reason why we see a malaria in this setting.
One may wonder, why is that not the case in every place where we have these freshwater lakes or big water bodies like Africana, other lakes in the country?
I'd want to tell you that we actually have pretty intense transmission of malaria in parts of Turkana, especially around the lake as well. And in coastal Kenya as well, which are pretty flat. So areas where we have rivers and the temperatures are conducive. So areas that are nicely warm and also have runoffs of water along lakes or major rivers, you will actually see malaria. And that's why you see like Kwale, for example, has pretty intense transmission in coastal Kenya. The areas around Turkana, Moyale, etc., they have small pockets of water that actually very conducive for mosquitoes. And so it almost follows that everywhere we see freshwater bodies of and some level of spillover, for some level of stagnation of water, you will see malaria.
I hear that people in Mombasa don't suffer from malaria. How true is that?
That's a myth. That is a myth. People in Mombasa also do get malaria. The thing is, coastal Kenya used to have very high prevalence of malaria, but then when BedNet started being implemented in the early 2000s, for some reason they had a better impact on malaria transmission, and therefore we saw massive reductions in coastal compared to Western Kenya. Yeah, but there is still some level of transmission.
Because I thought that probably it could be a matter of maybe the body getting acclimatized or something to do with the body kind of coming up with a way of sort of defending itself.
That is not really true. The thing is, provided you have malaria in circulation, you will always get people having having the parasite. So in Western Kenya, for example, even though we talk about a very high prevalence, for people who are born here and raised here, they develop natural immunity. And so you will, for example, go into schools in Western Kenya, and suddenly you realize that kids who are in some of these places, like in Siaya, for example, kids who are in primary school will have prevalences as high as 30-40%. So like what that means is basically if you go to a school in Siaya, of every 10 kids you see, over every 10 students, you'll probably have 3 or 4 of them having malaria parasites. But they're walking around, they're playing around, they're fine, they can't feel it. Because over time, because of frequent infection, they've actually developed some level of immunity. So that actually happens. That's the way the body tries to cope with persistent infection of malaria.
So is that to say that the people who've been born and bred in these malaria-prevalent areas like Western Kenya and some parts, of course, they can have the parasite in them, but they don't really get sick?
They can actually have the parasite and not show any symptoms, so they're what we call asymptomatic. But often they will at some point have a lapse in immunity and they will get infections. But usually it's very common that you will see a lot of kids in this place running around, but they actually have malaria parasites in them.
So will I be right to say that malaria in Western Kenya has not affected the children, especially their school life and their education and their day-to-day life because of the immunity?
No, you will not. So what usually happens is that eventually they will develop. Actually, more often than not, many of them will develop symptoms. And so they'll end up missing lots of school days. Actually, in places like Teso, in Busia, and even in Saya, we see a child having as many as 3 infections in a year, meaning that in 1 year they will have 3 different infections. And that is an average. In some places, that average is actually at 8. It means that in a 1-year calendar, this child is sick of malaria 8 times. So sometimes they are asymptomatic, sometimes they actually develop the infection, and when they do, it keeps them away from school. So there's a very high likelihood that children in areas like this will miss school because of illness. Children under 5 are more likely to die, but we actually even see mortality in children between 5 and 15 years of age due to malaria. And even now we even see it in adults as well. So malaria does affect them. Malaria does prevent their active cycle in terms of them being able to attend school.
And what about the adults? How does it affect adults, especially their economic life?
Have you ever had a malaria infection?
Yes, I have.
That feeling of nausea and headache, you literally cannot do anything productive during that time. Malaria is able to sustain this cycle of poverty because people are not able to work as they normally would work. Money that they ideally would have used to better themselves is spent buying medication and seeking hospital. They're wasting a lot of time in queuing in facilities trying to get care. So it does affect the productivity of entire community in this setting.
The malaria vaccine that was on pilot for some time, how did it go?
There are 2 vaccines now that are currently, one of them has already received, actually both of them have now received WHO recommendation. The first one is known as the RTSS vaccine. The second one is known as the R21 vaccine. So the RTSS vaccine was shown to reduce the chances of a child getting malaria by up to, I think, about 35%. The R21 vaccine is supposed to be more efficient. I think getting to as high as 80%, but I'm not so sure about the exact statistics there. So both of these are really excellent, and I think that they have the chance to reduce malaria transmission. There have been implementation trials done in Western Kenya looking at the uptake of the vaccine, etc. I just need to clarify that at the moment, the vaccines are given to children under 2 years of age. So they're usually, like the RTSS vaccine is given over 4 doses to children who are under 2 years of age. And the reason why that happens is because the vaccine works best for people who have not been exposed to malaria. So usually that's why it's best to give it to children under the age of 2. Mm-hmm. I think over time we will be able to see what impact it has in terms of reducing the prevalence of malaria, but so far I think it's probably too soon to speak of actual reductions in prevalence due to the vaccine.
So let's say that there are no statistics about its effectiveness yet.
No, there are statistics. From a trial perspective, I think it's able to reduce up to 35% of malaria infections.
35?
35, yes. That's for RTSS, and I think up to 80% for R21. But in terms of actual implementation trials, actually, in terms of actual reductions in prevalence and mass, I think that we still are not able to quantify. I could be wrong on this one, but it will take a few more years before we know about the actual impact of the vaccine in reduction of prevalence in the community.
Do you think the vaccine will be rolled out to adults, people above 2 years?
Good question. Not that I'm able to respond to.
Okay.
Yeah, that is not my forte. I wouldn't be able to respond correctly to that question.
Okay. In the story that the New York Times ran, where you are interviewed broadly, there is something that you said that was quite interesting, that we have new mosquitoes that don't wait until it's dark or it's night to bite, the ones that bite during the day. Could you please tell me more about that?
So I'll tell you two sets of stories, or two sets of species of mosquitoes. So the first one is what's known as Anopheles stephensi. That's the one that I've been seeing reports on media going about new killer mosquito, etc. So this is what happened. In Kenya, we have 4 main species of malaria: Anopheles gambi, Anopheles arabiensis, Anopheles fenestus, and Anopheles meras, which is restricted to the coast. It doesn't move beyond the coast because it breeds in salty environments. So those 3 are the most common ones across the country. Anopheles gambi and Anopheles fenestus are responsible for a lot of the infections, and the reason why they are is because they have a very strong preference towards biting humans, and also a very strong preference towards coming into the house to bite humans. That is why you see there's a huge focus towards mosquito control in products that are deployed inside the house, like bed net or indoor residual spray. Now, Anopheles stephensi is a vector that used to be restricted to Southeast Asia and the Arabian Peninsula. However, in 2012, there was a report about this vector being seen in Djibouti. And at that time, Djibouti was approaching elimination. They only had about 2,000 cases in the entire country. That was 2012. 9 years later, in 2021, Djibouti is now reporting 73,000 cases. So the cases have increased, and one of the major changes that has happened in that environment is the introduction of Anopheles stephensi, and actually this vector has taken over in that country. So we've seen that vector spread from Djibouti south into Ethiopia, into Sudan, into Somalia. And so as of December last year, we detected this vector in Kenya. So that is actually what the story was. Why we worry about that vector, Anopheles stephensi, is as the other vectors that we have in Kenya right now are mostly confined to the rural areas because they rely a lot on shallow breeding habitats. They come into the houses that have eaves and open windows and open doors, which you find most commonly in the rural areas. Anopheles stephensi is different because it has a big outdoor presence, so it bites people outdoors. It will bite people at any time, so it's very plastic in its response. We say plastic meaning that it has a very flexible behavior. It mostly prefers to bite cattle. And that is why it hasn't been we don't think it could be a big vector. But the reason why we worry is that in the absence of cattle, it's likely to bite humans a lot more prolifically. And if you think about the behavior, it also breeds very well in urban settings, in man-made containers. So this is a vector you're likely to see breeding in your tanks, in your car tires, in your dumped waste that contains containers. So anything that can hold water, Anopheles stephensi will breed in there, which is different from the other malaria vectors. The other reasons why we worry about it is because of that reason, it's likely to move into our urban settings. And if it does move to our urban settings, and you have people, for example, who are coming out of the malaria endemic areas who live in the city, then you're likely to establish malaria transmission in the urban settings. If that happens, then you're worried for multiple reasons. One, people who live in urban settings are from all parts of the country. Some of them are totally naive to malaria. They've never had a malaria infection. And what usually happens is that people who've never had a malaria infection have absolutely no immunity. So they tend to suffer more severe forms of malaria. And so you're likely to see severe malaria anemia in a lot of these areas. Number two, we have a very small budget for malaria control as a country. And so if you have more people, and especially people in urban settings starting to get malaria infections, then your funding that's currently available for malaria control in rural Kenya will get diverted. And that now then stretches our budget. It means that at some point you might actually run out of medicine that is enough for everybody and diagnostics that is enough for everyone. Number three, this mosquito is a very good vector of both Plasmodium falciparum and also Plasmodium vivax. So Plasmodium vivax was something that as a country we actually report very, very low cases of, if any at all. But then since the emergence of this vector in the country, now we have reports of Plasmodium vivax in Turkana, in Marsabit, in Malaria, coincident with the same areas where we're now seeing this vector, Anopheles stephensi. So those are the reasons why we worry about this vector specifically.
When you say that it has 2 types of Plasmodium, does that mean that it can spread malaria multiple times or different types of malaria? And I haven't quite understood that part.
So what we see most common in Kenya is Plasmodium falciparum malaria, which is one of the parasites. It's actually the most potent parasite, and it's a parasite that we have learned how to diagnose, so we have the tools to diagnose it, to tell that this is malaria, this is falciparum malaria. And number two, we can manage it very easily using artemisinin combination therapy, ACTs. Plasmodium vivax doesn't cause very severe infections, but it has what's called a liver stage. The liver stage means that when this parasite goes into the liver, it is away from the immune system. So it's impossible to target it with ACT medication. And so you need another type of medicine to be able to kill this parasite. Otherwise, people who have vivax infections will get an infection now. After a short while, even though you give them ACT, they will actually have another infection. It will relapse without them getting a new bite. So you get relapses. So you get frequent infections of malaria. So just think about the malaria symptoms. But now you're having them over and over again. You're feeling really bad multiple times. You're not able to work multiple times based on the same initial infection that you got. So that's what we're calling relapses. And so there's a specific drug known as Primaquine that is used to treat it. I don't know that the country, at the moment, we have any doses of Primaquine. And then also there's going to be that need to sensitize the communities towards the need to start equipping our pharmacies with Primaquine and on how to diagnose Plasmodium vivax. So those are the things that we worry about there. I don't know if that makes sense.
Now it makes sense to me. And you also mentioned about some specific type of mosquito that is in the coastal Kenya, the one that you say thrives in salty water areas. Is that the type of mosquito that causes dengue fever and chikungunya?
You know, people are dying of dengue fever right now in Burkina Faso. No, but that's a different type of mosquito. It's not an Anopheles mosquito. It's called an Aedes mosquito. Very, very prevalent in the coastal Kenya and parts of northern Kenya. But the mosquito I'm talking about is Anopheles maris. It also transmits malaria in coastal Kenya.
In Western Kenya, what are some of the things that you're doing to combat malaria infections?
So our research is what then feeds into policy. And so what we do at the moment is evaluation of different mosquito control tools. So our focus is usually on mosquito control. Some of the tools we are currently testing. Let me just go back a little bit and give you a bit of information on the regulatory process for vector control. So before we get to the point where, so you had, for example, the ministry buying bed nets, right?
Yes, sure.
And distributed free of charge to people who live in the malaria endemic settings. Before that happens, those products need to be approved by or recommended by WHO, World Health Organization. Now, for WHO to recommend a product, it's based on scientific evidence. And so our group collects scientific evidence. And so we do that in a number of ways. So there's phase 1 trials, which are basically lab trials, where we try out different products in the lab, try and figure out if they are working in the lab. And if they do work in the lab, then we move on to phase 2 trials. So phase 2 trials are conducted in what are known as experimental hut trials. So we have areas where we have very high densities of mosquitoes in Siaya, where we've set up experimental huts. And so often we get people coming to us with mosquito control products and we test them at that site. So that's one of the things that we do. And that's one of the ways that we encourage innovation. So people can come with different nets, different insecticides, different repellents, for example, and we test them at that facility. The last one is phase 3 trials, which are basically epidemiology trials. So when we have been able to prove that our product is able to prevent either mosquitoes from biting people or to reduce mosquito densities, then we try and look for what's known as epidemiological evidence. Epidemiological evidence just means we want to see whether by reducing these mosquito numbers or by preventing mosquitoes from biting people, we actually end up reducing malaria transmission. And so part of what we do, our team does what are known as phase 3 epidemiology trials, randomized control trials. And so these ones are done in very large areas. So for example, we are currently evaluating 2 products in randomized control trials. One of those products is known as partial repellents. And so these are devices that you place inside of a house, and that house becomes very unconducive for mosquitoes. And so what that does is that it prevents mosquitoes from either coming into the house or from biting people. And so we have 60 clusters, which are basically villages in Busia, where 30 of them we gave them partial repellents with the active ingredient, and the other 30 we gave them a product that looks like a partial repellent, but it does not have any active. And so we are comparing over a 2-year period whether the sites that received the product with the active will have reduced malaria incidence compared to the sites that did not receive the partial repellent actives. And so actually that project is now just coming to an end, and we have the results. So we have actually been able to prove that the partial repellents actually end up reducing malaria even further in this setting. And that's a very statistically significant finding. And so we are submitting our report to WHO now, as soon as the analysis is complete. And this should potentially be the first site that to prove this, and so when we have results from a second site, the product could be recommended by WHO. And so at that point, the country will actually be able to buy the product and distribute them to people who live in these areas. The other product we're evaluating at the moment in a randomized controlled trial is known as attractive targeted sugar bait. And so these baits basically rely on the fact that mosquitoes will always want to feed on sugar, and usually in nature they obtain that from plant juices or plant or flowers. And so this product basically is something that you hang outside of a house. It has a bait, but that bait also has a toxin, and then it has a membrane that covers the product so that non-target organisms like bees don't get access to the bait. And so as mosquitoes land on the bait, they're able to probe through the membrane, they access the bait, but they feed on it, it kills them. And so that evaluation is currently ongoing in CIA, and we want to see whether over a 2-year period we'll actually end up reducing malaria transmission. So that study hasn't ended, and so we don't have the results yet. So that's basically the way in which we evaluate different vector control products.
What about mosquito nets? I mean, are they sort of obsolete? Are they not working anymore?
No, so mosquito nets actually are the primary mosquito control method, and that is because mosquitoes will most often bite people in the middle of the night as they sleep. And so mosquito nets have actually been very, very, they have contributed to, I want to say, about 60% of the entire reduction in malaria between 2000 and 2015 because of mosquito nets. 68% actually, that's the figure. Mosquito nets continue to be very effective, they're very helpful. And now that you mentioned mosquito nets, they remain very effective. And so all of these new products we're evaluating will be used in addition to mosquito nets. Okay, so people must continue to use the mosquito nets in addition to these new tools. But let me also mention one other concern that is coming up. We've actually just written about this in Malaria Journal. We are also seeing this species of mosquitoes known as Anopheles fenescus. What's happening with that species of mosquitoes is that we actually see that in the past they used to bite people in the middle of the night, and so if you had a net over you, you're protected. But now we're seeing that they're shifting in their biting behavior so that they're starting to bite people actually early in the morning, and they can bite people as late as 11 a.m. in the morning. So they actually wait for you to get outside of your bed net, and then they bite you at that point. And so that's one of the reasons why you need new tools to protect people during that time when they're not under their bed nets, but mosquitoes are active.
Is that to say that mosquitoes have also sort of known the trick?
Exactly. Just so you know, the idea of speciation, Charles Darwin and the survival of every species is trying to survive, including mosquitoes. They're also trying to survive. And that is the reason why you really want to, we have to keep doing our research to ensure that we up whatever tools that are coming into play will be effective against mosquitoes, because mosquitoes are also changing, and they're changing a lot to try and survive whatever tools we throw against them.
Up to this end, have we had any invention that have been impactful breakthroughs so far?
I want to say that maybe the biggest breakthrough for mosquito control has been bed nets. I mean, bed nets since the year 2000, when we used to have prevalences of almost 80%. Bed nets have brought that prevalence down to 40%. So they almost have the entire burden of malaria, and that bed nets plus indoor residual spraying. So those two tools have been very, very, very impactful. We're evaluating new tools, so we hope spatial repellent is one of those new tools that will also be impactful in this space. But we're also looking at new tools and also assessing some of the old tools like larviciding, for example, the control of mosquitoes at the larval stage. So we're evaluating all those types of tools to see if any of them would actually help to contribute to further reductions in malaria transmission.
And from where you stand, what do you think is the future of malaria? Like, are we doing better? I mean, going forward, do you think these cases are going to reduce further and further, or we might get some sort of an about and we have a surge?
Good question. And my opinion is this. If we don't do anything differently, if we continue to just do everything like we are doing right now, we will have increases in malaria. And honestly, we are already seeing that. Like if you compare the numbers of the cases of malaria that were seen in 2020 versus 2021 versus 2021, according to the World Malaria Report, there was an increase in cases. So at the moment we are stagnating. The problem with stagnating or staying at the same level is that it's very hard to stay at the same level. You are either always going to be reducing malaria or you will see an increase in malaria. And so at the moment we have to try and add additional tools, and that's why our research is very important in the fight against malaria, for us to continue to see additional declines in malaria transmission.
Okay, and what could you say is the main or the biggest challenge or impediment to the fight against malaria in Kenya currently?
A number of things. Of course, the biggest one would be funding. If we had unlimited access to money, all of these tools could be distributed everywhere. So things like indoor residual spraying are very effective at reducing mosquito numbers very quickly and therefore reducing malaria burden. But it's very, very expensive to implement indoor residual spraying. Actually, I think it costs about, I want to say $20 per structure to implement IRS. So it's very, very expensive. And so that's why the government is not able to do it everywhere. One of the challenges is bed nets. So there's resistance in to most of the insecticides that we currently have. Actually, the ones that are used on bed nets mostly. The beauty is there are new nets that are coming up that are either combine multiple types of insecticides. So either something called piperonyl butoxide, which is a synergist in addition to the pyrethroid bed nets, or new insecticides like clofenapir and something else known as pyriproxyfen. So those are new nets that are coming up that we hope we can be able to use in the areas where we've seen resistance. The problem is those nets are more expensive than the standard bed nets. And so, of course, it's always going to be a point of trying to balance and ensure that you have maximum coverage for everyone who's at risk of malaria, while at the same time ensuring that you are able to bring an additional reduction. The beauty of what I do is that the work that I do has contributed to policy around bed net distribution, policy around indoor residual spraying, and the use of superior insecticides. And I can tell you that Homa Bay is the one county that used to have a prevalence of about 19% for malaria as of 2015, but as 2020, Homa Bay had a prevalence of 4%. And that is because of the introduction of indoor residual spraying with organophosphate insecticides, which are much more superior. And so, the work that we're doing is actually contributing to reductions of malaria in this setting. Number two, the bed nets that we're involved in a lot of evaluation of new types of bed nets. And so some of those superior bed nets are currently being distributed in areas like Busia, Kakamega and Bungoma in the last campaign. But in this campaign, they're actually being distributed also in Homa Bay. And so those are products of the research that we're doing as a department. So I'm very, very proud of that.
Great.
What I'd urge people to do is to continue to use the vector control interventions, continue to use the bed nets, and where possible, there are basic ways in which you can keep mosquitoes away. So for example, things like covering any water containers, draining any stagnant water around us, slashing of bushes, for example, clearing any waste that we have. Those are things that we need to continue to do as a community of practice because they really help to keep away mosquitoes, which are the ones that cause all of this vector-borne diseases that we're talking about.
Asante sana.